what's on my mind, number one, is encouraging people to enjoy this next month of summertime. Now that I've moved back to the East Coast after being on the West Coast for 11 years, I've got to get used to the seasons again. And East Coast people are very, very tuned into seasonality. I haven't been. But now that this is I think, almost end of 3 years here at Weill Cornell, I'm getting the hint that you got to enjoy August because it is considered to be the last month of summertime. Go figure. So please do enjoy the month. The other thing I note coming to August, which is different than July when we're really just starting the new academic year, celebrating the end of the old academic year. Well, in August, things change again. We welcome new MD students, new PA students, new graduate students. And so the campus starts gearing up about mid-August for the welcoming of new people to our community. So the two things that are on my mind, getting and encouraging more vacation time for our faculty, staff, students, and getting ready to welcome new members of our community later in August. That's what's on my mind. Oh, I love ice cream, but I'm a simple person. I like things like vanilla ice cream, but if I have vanilla ice cream, I like it topped with caramel sauce. I love caramel sauce. But my favorite ice cream is probably Ben & Jerry's Cherry Garcia. All great flavors mixed together, and we always have it in the freezer, not just in the summer, but all year long. We have a crisis in this country around primary care. We don't have enough primary care clinicians, and we have an aging population with a lot of chronic disease in the population that really does benefit from the coordinated care of primary care. So how do we make it more attractive to our medical students? I think there's a number of issues here that overlap with one another and can't really be thought of in isolation. We have the compensation issue. We have a payment system for physician services in this country that way undervalues the importance of the organization of chronic care. We've got to somehow address that through how we pay physicians. That has got to change. And there are a lot of interesting policy discussions underway about value-based care, paying for value, et cetera. We've got to figure that out. Secondly, I think we've got to acknowledge and embrace the notion of team-based care. I'd like to think that it's not so much one doctor, one patient, which is an older model or the traditional model of primary care, but one patient, one team, and really bring together teams of clinical providers that really deliver primary care for a patient and a population of patients. So our advanced practice clinicians, PAs and NPs, our nurses, RNs, our medical assistants, pharmacists, social workers, occupational therapists, physical therapists, all of that makes up a team. And so trying to figure out how do we deliver care in a team-based format, I think could make it very exciting for physicians who are interested in primary care. Being part of a team, in many cases leading that team, and maybe the physician digging into the most challenging problems while the team can handle some of the more routine issues. It also allows us to bring in expertise. Pharmacists on the team is a great example. Sometimes, rather than having the primary care physician go over the side effects of a new medication, perfectly done by a pharmacist colleague. So let's really rethink how we're delivering primary care. Let's think about teams, and let's change the compensation model for primary care in this country. Patients with chronic diseases, cancer, heart disease, metabolic disorders, neurodegenerative disorders, when should they consider entry into clinical trials, or maybe a larger framework, when should they enter into clinical research? From the day they first understand that the best advances are going to be made by participation in research. I don't say that lightly. We know that people who enter clinical trials not only get access sometimes to innovative care models, innovative therapies, new technologies, but we know that people who are in clinical research projects, including clinical trials, actually fare better compared with patients who are not in trials. And there's probably a lot of reasons for that. Some of it may be a selection issue, but some of it undoubtedly is due to the care and attention that research professionals pay to patients who are in their clinical trials. There tends to be better attention, for example, paid to concomitant medications, in addition to the ones that perhaps are being studied in that clinical trial. There's a higher use of other medications that are evidence-based, that are guideline prescribed. So when should people think about clinical trials? As soon as they know that they have a chronic disease. When there's a disagreement about patients' care, how do I approach the communication issues? I think first off is make sure that you're willing to have the communication issue. So a willingness to participate is really critical. Second is that use data to drive decision making, but don't deliver messages about data in an authoritarian way. Make sure that you maintain an openness to other perspectives. Make sure that you treat people civilly and with respect and professionalism. All of those things I think are critically important so that you can have the kind of decision that you can arrive at the kind of decision that's based on data, that's based on a thorough discussion, that's based on understanding an individual patient's values and preferences, and that's all done in a respectful manner. That, to me, is the essence of communication when people disagree. What kind of potential do I see for new peptides used by our patients, by the population, maybe more writ large? This is a really important issue that's been in the news lately because of the push from the Secretary of Health and Human Services. There was a recent FDA advisory panel meeting on this. Unfortunately, a panel that was stacked with pro-peptide people. That's usually not the way that these advisory committees do their work. Nonetheless, what do we know? Here's what we know. We know that the vitamin industry, for example, vitamin and supplements, have been able to escape a lot of the FDA oversight because of laws that were passed decades ago. That's not been good. We have a multi-billion-dollar vitamin and supplement industry with little evidence supporting either efficacy or safety in their use. And over the years, there's been problems with that. The peptide market might even be more problematic. Here are agents that put forward that they have important medical usage, and they might, but we don't know that for a fact. We need clinical trials. We need clinical studies to be able to tell us what is the balance of efficacy and safety. Just putting these out for choice on the market is not a wise idea. We have all sorts of examples of things entering the medical marketplace too early without adequate safety and efficacy clinical studies to be able to document what is that balance. What we're currently doing with peptides is not wise. Oh, the fictional character. I think I've talked about this before on video. I am a big fan of the Gabriel Allon series by Daniel Silver, and a new book comes out every summer around mid-July. So I am partway through Daniel Silver's latest book called Ransom, which is really the protagonist, Gabriel Allon, who is a Catholic art restorer who's also happens to be a spy. He's now in retirement, but his spy skills are being put to use in his new book called Ransom. And I advise many people to go out and start at the beginning of the Gabriel Allon canon so that you can understand over the last many years why I've become such a big fan of this book series.